Welcome. I hope you guys are enjoying the day as much as I am. Before I get to my introduction, I want to remind everybody to review faculty availability for office hours and schedule a time to connect with one of our faculty members. Now I want to introduce Dr. Stephen Hanauer. He is a world-renowned gastroenterologist and IBD specialist currently at the Northwestern University Feinberg School of Medicine, where he is a professor of medicine. I want to remind you, if you haven't already, please take a moment to answer the polling questions. This activity is supported by an independent educational grant from AbbVie, Bristol Myers Squibb, and Janssen. Hope you enjoy the lecture. I'll see you on the backside.
Hello, I'm Dr. Steve Hanauer from Northwestern University in Chicago, and I'm pleased to provide a discussion on the improvements in targeted inflammatory bowel disease management, innovative biologics, and small molecules that are near to our future. These are my disclosures. The learning objectives for today's session are to describe the limitations of current therapeutic targets for the management of IBD, to assess clinical data on newer and emerging IBD treatments, including safety and efficacy profiles and mechanisms of action, and how we are going to continue to employ treat-to-target IBD management practices for improved patient outcomes. The pathogenesis of both ulcerative colitis and Crohn's disease are very complicated, and they are essentially a puzzle, including activating factors, our gut microbiome, both protective and potentially harmful components or metabolites of the microbiome, our genetic underpinnings for genes that regulate our immune responses in both ulcerative colitis and Crohn's disease. The universe of immune and non-immune components in the pathogenesis are, again, exceedingly complex, and they include components from the environment, including our microbiome, our immune system, and how the immune system interacts and bidirectionally with our genes. So the complexity, when we put together the number of genes, the number of microbiome components and their metabolites, as well as the components of our immune system, this really contributes to the challenge in identifying factors that will improve the outcome of this chronic inflammatory set of disorders. To date, our treatments have focused on either environmental triggers, such as cigarette smoking, and we know that smoking is a protective effect in ulcerative colitis and negative in Crohn's disease. And there's considerable effort in identifying dietary factors as well. The majority of our efforts have been focused on the immune system, where, as I will show you, our therapeutic agents have had a modest but somewhat limited efficacy. To date, microbial therapies have been quite limited, mostly to the setting of pouchitis or fistulizing disease, but not for the primary immune events in either ulcerative colitis or Crohn's disease. And to date, we really have not been targeting our genome, but this has potential for the future. So when we break this down, about 5% of our therapeutic targets are engaging the environment, 10% the microbiota, and the vast majority our immune system. Our societies have evolved a therapeutic algorithm that is based on the severity of the risk for progressing from non-complicated or superficial inflammatory bowel disease to more complex disease. In the setting of ulcerative colitis, the risk of colectomy, and in Crohn's disease, the risk for evolving into transmural complications. For patients who are at low risk for colectomy, and these are patients with limited disease and superficial disease, mesalamine or non-systemic steroids have been advocated. However, for patients who have a high risk, which includes patients with extensive colitis at young age, individuals who have required corticosteroids, or patients with deep ulcerations, our societies have advocated an option of either steroids with or without immunosuppressives, TNF inhibitors with or without immunosuppressives, Etrolizumab with or without immunosuppressives, Ustekinumab with or without immunosuppressives, or Tofacitinib without immunosuppressives. In the setting of Crohn's disease, the risk factors for progressive transmural disease include an extensive extent, presence of perianal complications, young age at diagnosis, cigarette smoking, or prior resections. In addition, deep ulcerations are a significant risk for progressive Crohn's disease to either strictures or fistula. In the low-risk population, those individuals without those risks for progression, non-systemic steroids is really the only initial approach that has been tested and shown to be effective for patients with mild to moderate Crohn's disease. Similar to ulcerative colitis, our options for patients with moderate to high risk of progression include steroids with or without an immunosuppressive, TNF inhibitors with or without an immunosuppressive, Etrolizumab with or without immunosuppressives, or Ustekinumab with or without immunosuppressives. Nevertheless, there are significant barriers for our patients to achieve long-term therapeutic success. These include a rapid onset of action, a significant proportion of patients with primary or secondary non-response to biologic therapies. Biologics can be hampered by immunogenicity, and a limited number of options that have been effective for patients who have been previously exposed to TNF inhibitors. And all of these agents are also somewhat compromised by risk or safety complications. So the development of novel therapeutics is driven by these unmet needs. Based on these barriers, there is certainly significant room for improvement within our biologic era. TNF inhibitors will provide about 2/3 of a patient's clinical response, but somewhat less than 20% clinical remission in the induction phase. In the maintenance phase, somewhat less patients have a prolonged response, but somewhat more achieve clinical remission as those responses continue to evolve to further depth of response, including remission. As far as patients' needs are concerned, there are differences in our patient-physician relationships and a need for extensive shared decision-making in discussions of the variety of different options. Many of our therapies are inconvenienced by either infusions or need for frequent injections. There are limits on the long-term efficacy and safety, particularly with the TNF inhibitors, and patient compliance or adherence is necessary for patients to have the longer term benefits of these variety of different therapies. Ultimately, costs are also a significant concern because in 2021, we really cannot afford to treat all of our patients with moderate to severe ulcerative colitis or Crohn's disease with the highly expensive biologic therapies. So we need to find more cost-effective therapies over time. Despite the unmet needs, we have found significant advantages in treating to target for patients with both ulcerative colitis and Crohn's disease. This is similar to our other chronic diseases, such as hypertension, type 2 diabetes, or rheumatoid arthritis, where treating to targets have actually improved long-term outcomes. Now, in both ulcerative colitis and Crohn's disease, treating beyond symptoms alone have also improved longer-term outcomes. In the setting of ulcerative colitis, when we treat beyond symptoms to endoscopic healing, restitution of the mucosa, we actually can reduce the risk of colectomy. When we go one step further and treat to normalization of the histology, we can actually reduce the risk of clinical relapses as well as reducing the risk of cancer. Similarly, in Crohn's disease, it has been essential to treat beyond clinical symptoms because there is very poor correlation between symptoms, biomarkers, and endoscopy. Clinical trials thus far, such as the CALM trial that I am not going to discuss in detail, have randomized patients to treating to symptoms alone with escalation of therapy based on symptoms alone, or escalation of therapy based on symptoms or elevated biomarkers. When we treat to biomarkers with or without symptoms, we actually improve endoscopic outcomes. To this point, histology has not become an important aspect of treating to target in Crohn's disease, but we can envision in the future how this will potentially be incorporated as reproducible and validated indices of histology come to fruition. Based on the complex pathogenesis of both ulcerative colitis and Crohn's disease, we are learning that there are additional potential targets, including the gut microbiome, restitution of the epithelium, as well as immune interactions with both reducing pro-inflammatory cytokines and potentially stimulating anti-inflammatory cytokine therapies. There are a number of key classes of emerging therapies that are entering or near concluding phase 3 studies, anticipating near future availability of these different agents with different mechanisms of action. We have learned by Etrolizumab that lymphocyte trafficking is an important mechanism that can be modulated in both ulcerative colitis and Crohn's disease, and there are a number of evolving formulations that I will discuss in a minute. The availability of ustekinumab that inhibits both IL-12 and IL-23 in Crohn's and ulcerative colitis as a very effective therapy is being extended to therapies directed at IL-23 alone without inhibition of interleukin-12. Also nearing the marketplace is a new set of therapies for inflammatory bowel disease that are known as sphingosine 1-phosphate receptor modulators. Ozanimod has already been approved for multiple sclerosis and is nearing approval for inflammatory bowel disease, and I will show you some of that data in a minute. And the availability of tofacitinib for patients with ulcerative colitis who have had an inadequate response to TNF inhibitors has opened the door for additional and more selective Janus kinase inhibitors. Let's begin to review some of the potential targets for lymphocyte trafficking. Already, we have learned that natalizumab, which interferes with the alpha-4 integrin connecting to the vascular cell adhesion molecule, has been effective in both multiple sclerosis and Crohn's disease, but because of its inhibition of lymphocyte trafficking within the brain, natalizumab has lost favor and has only limited value in the setting of Crohn's disease. But we've now recognized a number of other potential targets within the lymphocyte trafficking arena. Vedolizumab, an alpha-4 beta-7 antibody that targets the receptor interaction with the mucosal addressin, or MADCAM, has been already approved and is in use as a safe and effective therapy for both moderate to severe ulcerative colitis and Crohn's disease. Additional potential targets include the beta-7 integrin, which I'll discuss in a moment, as well as anti-MADCAM antibodies. And then eventually I will discuss how the sphingosine 1 phosphate receptor modulators can impact on lymphocyte trafficking. Etrolizumab is what could be called a next generation gut-targeted anti-integrin. Vedolizumab targets the alpha-4 beta-7 receptor that allows 3% of the T lymphocytes to enter into the mucosa. Beta-7 can also be targeted, and beta-7 is not only important with alpha-4 beta-7 for entry into the mucosa, but it's also an important target that will improve egress or allow the cells to move out of the mucosa. Etrolizumab both blocks the entry and the exit of cells from the mucosa, from the bloodstream in, and also allows the lymphocytes out via receptors with the E-cadherin, as you can see on this slide. In phase 2 studies with etrolizumab in the setting of ulcerative colitis, we could see that there were significant benefits compared to placebo for both clinical remission in patients who were on or off steroids, and also for patients who were naive to biologics, in this case, TNF inhibitors, with less response in this small group of patients in the phase 2 study who had previously been exposed to TNF inhibitors. And this is a continuing story, as the clinicians already recognize that once patients have been exposed to TNF inhibitors, it's much more challenging to get a good response with subsequent biologic treatments or even small molecules. Most recently, a very large phase 3 study was performed to evaluate etrolizumab in the setting of moderate to severe ulcerative colitis. However, the primary endpoint of this study, which was remission at the end of a year, while numerically advantageous for etrolizumab, was not overall statistically significant. So unfortunately, in this large clinical trial, etrolizumab failed to meet its primary endpoint. Nevertheless, there were a number of significant secondary endpoints that were beneficial and statistically significant, including histologic remission, endoscopic remission, remission in patients who had remitted at week 10, who continued their remission out to a year, as well as corticosteroid-free remission. Nevertheless, it failed to meet its primary endpoint of clinical remission at the end of the year. Etrolizumab appeared to be safe in this clinical trial with no significant safety signals compared to placebo. Etrolizumab is continuing additional studies in the setting of inflammatory bowel disease, and a phase 3 study is ongoing in the setting of Crohn's disease. Another potential lymphocyte targeting therapy would be blocking MAdCAM, similar to the interaction of vedolizumab with MAdCAM by inhibiting alpha-4 beta-7, instead by inhibiting the MAdCAM addressin itself. Unfortunately, the development is currently on hold, and the initial clinical studies that look promising are not furthering in development at this particular time, but perhaps in the future. Now, another class of therapies have evolved from our experience with ustekinumab. Ustekinumab is an agent that targets the P40 receptor that is present on both interleukin 23 and interleukin 12, and has been effective in moderate to severe ulcerative colitis and in moderate to severe Crohn's disease, and has been on the market for several years in both of these diseases, as well as psoriasis and psoriatic arthritis. The interleukin 23 receptor also invokes a P19 receptor. And there are a number of drugs under development targeting P19, so there is sole inhibition of interleukin 23 without impacting IL-12. There are some potential advantages of limiting the inhibition to interleukin 23 alone. And you can see that under development are risankizumab, brazikumab, mirikizumab, and guselkumab that are under development for inflammatory bowel disease, and some have actually been approved in the setting of psoriasis. Brazikumab has been tested in moderate to severe Crohn's disease in a phase 2 study that demonstrated improvements in clinical response and remission at week 12 and at week 24. Risankizumab has also been tested in moderate to severe Crohn's disease with positive preliminary results for efficacy. And you can see one of the interesting aspects of risankizumab in the most recent studies suggests that they're, in contrast to other biologics that have had decreased efficacy in bio-exposed patients, the efficacy seems relatively stable in both bio-naive and bio-experienced patients, at least at week 12. Moving on to another class of agents that are going to be soon to the market in inflammatory bowel disease are an expansion of our experience with tofacitinib in ulcerative colitis. Tofacitinib is a relatively non-specific Janus kinase inhibitor. Additional, more specific Janus kinase inhibition are targeting the JAK1 receptors that seem to be more prominent in the immune setting. As I've already mentioned, tofacitinib is approved for ulcerative colitis, under development and in phase 2 and 3 studies. Both filgotinib and upadacitinib are being tested in both ulcerative colitis and in Crohn's disease. Filgotinib has been tested in ulcerative colitis in what's known as the selection study, which was a phase 2b/3 trial in moderate to severe ulcerative colitis. The efficacy was demonstrated to be superior to placebo in both bio-experienced and bio-naive patients at week 10, as well as in maintenance therapy. And the safety profile for filgotinib looks very good. And we're going to see whether some of the immune suppressive effects, as well as the thromboembolic events related to tofacitinib, pass through as we get to more selective Janus kinase agents. Filgotinib has also been tested in a phase 2 study in the setting of Crohn's disease, a relatively complex protocol here, but the results do look promising for both clinical remission and clinical response in these phase 2 studies at the end of 10 weeks. Likewise, the safety results appear to be quite promising for filgotinib in the setting of inflammatory bowel disease. And most recently, upadacitinib has been tested in phase 2b studies in active moderate to severe ulcerative colitis, where the results again are superior to placebo, although the dose response still remains to be clarified at the higher doses of upadacitinib. In addition to clinical responses, upadacitinib has demonstrated endoscopic and histologic improvement, although the final dosing for inflammatory bowel disease remains to be determined. The safety for upadacitinib, similar to the safety for filgotinib, looks very good and is barely distinguishable compared to placebo, although we certainly anticipate that these Janus kinase inhibitors are going to have some immunosuppressive aspect with the likelihood of risks of infection over time. But the comparative effectiveness and the comparative safety with tofacitinib remain to be determined. In the Celeste study in moderate to severe Crohn's disease, upadacitinib has also been tested in both induction and maintenance therapy, with promising results as well as far as clinical remission and endoscopic remission on the left at week 16 and on the right at week 52. The safety results again look very promising, with small signals of immunosuppressive risks. Now, moving back to the concept of lymphocyte trafficking, the sphingosine 1 phosphate receptors are very important for trafficking of lymphocytes throughout the body, and in particular within lymph nodes. The gradient of sphingosine 1 phosphate allows the recruitment and maneuvering of lymphocytes out of the lymph nodes into the circulation, and inhibition or modulation can actually trap the lymphocytes within the lymph nodes and be manifest by actually reduced lymphocyte counts in the peripheral circulation. This mechanism has been demonstrated to be effective in the setting of multiple sclerosis, and trials now are underway with several sphingosine 1-phosphate receptor modulators in the setting of inflammatory bowel disease. Ozanimod is the nearest to approval. It has been approved for multiple sclerosis and now has completed phase 3 studies in the setting of ulcerative colitis. Ozanimod has reached its primary endpoints of clinical remission and additional endpoints of clinical response, endoscopic improvement, maintenance of remission, steroid-free remission, endoscopic healing, and durability. At week 52, in patients with a prior TNF exposure, there also has been evidence of clinical remission, clinical response, and endoscopic improvement, which may allow another agent for patients who have lost response or have had an inadequate response to TNF inhibitors. And the safety profile for ozanimod has also looked quite good, with minimal risks of serious adverse events, and in particular, opportunistic infections. Now, this list that I've gone through has by no means been inclusive. Additional therapies are also being evaluated in earlier phase studies, including stem cell therapies for fistula, TYK2 inhibitors within the JAK kinase series of agents targeting gut microbiome, different aspects of the immune response, stimulating anti-inflammatory compounds, as well as others, including bacterial spores and other microbial agents in the setting of ulcerative colitis, similar to what we've seen in the setting of treating Clostridium difficile. Now, the treatment and the approach to inflammatory bowel disease, going back to my introduction, is extremely complex. And the complexities include the environment, the genes, the microbiome, and the immune system. What we've learned is when we target a single one of these, when we target only a single one of these components, we have been limited by this therapeutic signal. In the future, we need to be looking at combinations of therapies that will affect more than a single component within this complex interactions that lead to chronic immune inflammatory diseases. But combining therapies has also had limited experience as well as limited benefits to date. That's not to say that we shouldn't be looking more in the future. Combining infliximab and natalizumab has had a tendency towards improvement, but limited study. Anti-TNFs and vedolizumab have been used in combination in individual patients with combining diseases such as inflammatory bowel disease, pyoderma gangrenosum, or spondyloarthritis. We've also learned that ustekinumab can be useful for patients who have developed psoriaform rashes related to TNF inhibitors. And similar to other immune-mediated diseases, combining agents has some potential for therapy in the future, but is going to be complicated by the expense in clinical trials. So when we look at this three-compartment model of the immune system, the epithelium, and our gut microbiome, again, we're dealing with 250 genes, thousands of species, and to come up with individualized medicine looks to be a very challenging process. Likewise, inflammatory bowel disease, as I've already alluded to, can also include systemic manifestations, including central or peripheral arthritis, skin manifestations, eye manifestations, as well as perianal fistula, all particular targets of potentially combining therapy. And attempts at combining biologics at the moment are going to be limited not just by safety, but also by the cost of combining two very expensive treatments. So I've already discussed this. One thing that we have not yet discussed is diet. And currently there are a number of dietary modifications that can improve outcomes and are particularly useful in children. Elemental diets have had benefits for both reducing signs and symptoms, biomarkers, and endoscopic healing, but really hasn't been practical on a long-term basis. Newer trials are underway to compare different diets in the setting of Crohn's disease, such as the Mediterranean diet versus a simple carbohydrate diet, what's known as the DINE study, and we're very much looking forward to seeing results of this completed trial. But instead of impacting individual components or individual nodes, we need to be considering the treatment that look at a variety of different nodes that may be different in the different phenotypic expressions of inflammatory bowel disease. We've learned that single node interactions such as TNF inhibition, IL-23 inhibition, Janus kinase inhibition, all have a therapeutic ceiling and do not encompass the entire spectrum of inflammatory bowel disease. By expanding our notion of these interactions in the bottom right, we may be able to improve overall that ceiling and raise that ceiling for our patients. But this is going to be very complicated in drug development when we look at all of these different factors to identify what specific interactomes are going to be relevant, effective, and safe in the individual disease scenarios. At the present time, we are selecting therapy by their rapidity of induction of remission, assessing early non-clinical signs of response, the importance of durability, patient preference for mode of administration, safety has been first and foremost, the ability to improve endoscopy and histology are increasingly important. We need to be able to modulate immunogenicity and reduce that with biologic therapies. We need to be encompassing extraintestinal manifestations. And as I've repeatedly emphasized, the issue of cost remains substantial in the treatment of our immune-mediated inflammatory diseases. So in summary, what I've discussed today is the plateauing of efficacy and the potential need for combination therapy, but first and foremost, predictive biomarkers to better enable precision medicine. There are a number of promising new classes under investigation that include both small molecules and biologics, and we would anticipate over the next 12 to 24 months, new Janus kinase inhibitors coming onto the market for inflammatory bowel disease, new lymphocyte trafficking antibodies, interleukin-23 antibodies, S1P modulators, and there are many others in clinical development. We have learned that treating to target improves overall outcomes. The deeper the target, the better the longer term responses to treatment and the limitation of side effects from treatment and the disease itself. And as these new agents come onto the market, we really need to assess their safety profiles, not only in clinical trials, but in real-world experience. The future of inflammatory bowel disease is going to include our present assessment of disease severity to predict the course, selection of treatment, treating to target therapy, modifying therapy based on our inability to achieve the target, continuing this iterative process of modifying and achieving targets until we get there. But what are greatly needed are new predictive tools in the realm of omics, better markers, both serologic and fecal markers, to determine efficacy of individual agents and to determine better prognosis. We shouldn't be delaying surgery in all patients with Crohn's disease, as now that we have learned that postoperative prevention can be very effective rather than beating a dead horse of continuing to try to get an inflammatory stricture to open up rather than operating and starting anew with clean margins overall. So I hope that this discussion has been useful as we take our magic ball and try to look into the future. And I look forward to your questions in the session.
Thank you. It is my pleasure to welcome Steve Hanauer in person. He is a giant in the field of inflammatory bowel disease, a mensch and a mentor. Unfortunately, we only have about 4 minutes live with Steve, but I have some great questions from the audience. I'm going to start with one I think I really like, and I think Steve will like. It comes from a rheumatologist who says that he's observed that his GI colleagues are not as aggressive as treating IBD to target. Why?
Well, that is a great question, and I'm not certain that I agree with it totally, because over the past decade, we've actually followed along with rheumatology and diabetes and hypertension, trying to identify targets. But what has actually happened is our targets have started to move, not so dissimilar from rheumatoid arthritis. Our targets have evolved from clinical targets, meaning clinical improvement and clinical remission, which improve quality of life, to endoscopic targets that actually start to impact on the natural history of the disease. So with endoscopic healing, we can now achieve less hospitalizations and surgery. And now in the setting of ulcerative colitis, when we actually achieve the histologic target of normalization, we reduce relapses and cancers over time. But this has been an evolution. And one of the other problems that we have is, just like in rheumatoid arthritis, if you have a patient with pre-existing structural damage, joint damage, in the case of Crohn's disease, strictures or fistula, we can't always achieve our normal anticipated targets. So there is a bigger move along these lines, but we're still confronted with a large proportion of patients who just don't achieve those targets.
Yeah, that's absolutely true. And another good question just came in, and we have about 1 minute and 40 seconds left. Gastroenterologists have more experience with biologic use during pregnancy than rheumatologists. So they want to know which biologics are safer in pregnancy.
Well, first of all, our IBD patients tend to be younger than the rheumatologic patients. So we've been dealing with pregnancy all along. And we have learned from our ancient or conventional medicines that sulfasalazine and mesalamine are safe in pregnancy. Between our specialties, we've seen that steroids are generally safe. And now one of our colleagues, Uma Mahadaman, has done a large registry called Piano in inflammatory bowel disease, looking at the biologics and actually encompassing some of the new small molecules such as JAK inhibitors. Thus far, none of the biologics that we use, TNF inhibitors, anti-adhesion molecules, IL-12/23 inhibitors, have had any negative impact on pregnancy. So our tendency is to now treat through pregnancy with the biologics.
Excellent. And I know one of the interactive cases that we'll have either tomorrow morning or Sunday morning will have to do with pregnancy and how rheumatology, dermatology, and GI approach this a little
Great
bit
segue.
differently. Again, in 4 seconds, I hope to see you soon.
Bye-bye.